Good afternoon, everybody. This is Jennifer Bright, the Executive Director of the Innovation and Value Initiative, and we are so pleased to welcome you this afternoon to our first in a three-part series on the intersection between health equity and value assessment. Today's session, titled Meaningful Action Towards Health Equity, as I said, is the first in a three-part series, and we can go to the next slide. I just want to take a moment to frame the intent and the vision that IVI has for this conversation over the course of the next several sessions. First, we know that given recent news, current events, discussions in any number of journals and industries and conferences, that health equity is on the radar screen of many organizations and individuals. And I thought from a framing perspective, it would be healthy to start with, what are we talking about? What's our lens for the concept of equity? And I drew directly from the Robert Wood Johnson Foundation definition, and this organization obviously has been investing in research and policy considerations with how we address gross disparities in everything from research to delivery of care. And so we really are talking about, in essence, a fairness principle, but also the importance of a healthy society, and that every individual in our society has the opportunity to be as healthy as possible. So that's our framing. But I also, you can go to the next slide. I also want to put this broader concept and discussion in context of where IVI sits and what we really want to focus on, because as you know, health equity is a very broad topic, and we're not trying to boil the ocean. But the intersection for us at IVI is that health equity is one of our main driving principles in what we do in methods and in process to improve both the discussion and the practice of value assessment in the United States. And we recently published a set of principles that really guide our thinking and our action. And obviously one of those, one of many, is that it supports health equity. And what do we mean by that? For IVI, it's about how we grapple with the methods and the data inputs that are needed to really have a balanced conversation about value in this country. And we know that in the area of value assessment, there are many challenges in terms of representing patient lived experience and preferences adequately. We have issues with regard to representativeness in clinical trial data. And so all of those things then exacerbate what happens on the other end, the outputs about what is optimal care, what is best delivery mechanism, what is best payment structures. And so from where IVI sits, one of our reasons for hosting this series is that we feel very strongly that the methods and the concept of health equity have to be a driving force. They are integrally linked with patient-centeredness. And we are concerned that if we don't have a vigorous conversation about methods and about data and about patient centricity, then we are very much at risk of making decisions in the United States about value, and that hard code some of the existing disparities in care. And so that is really our driving impetus for this series. And I'm very pleased today to welcome three terrific speakers. We can go to the next slide. So over the next hour or so, we're going to hear some perspectives from these three individuals. First, we have Dr. Michelle McMurray-Heath, who's the president and CEO of the Biotechnology Industry Organization. And I had the pleasure of working with Michelle last year on a webinar series during the time of COVID. But I know that across her career, she has been very dedicated to the notion of how we bring patient perspectives forward in research and in policy deliberation. So she'll be reflecting on industry and innovation, but also the responsibility of that community for improving data and the conversation about equity. Next, we're going to hear from Dr. Upal Roy, who is the Vice President of Research at the Longevity Foundation, certainly both an embodiment of patient perspective, and also the intersection with the challenges in conducting and bringing forward research that can really help us understand um, these concepts of equity. And then lastly, but certainly not least, Dr. Latasha Lee, who's the Vice President of Clinical and Social Research and Development at the National Minority Quality Forum. We will be posting a link in the chat of a paper that I know she'll be speaking from, talking about these principles of equity and directly their intersection with the concepts around value assessment. So we're going to hear from each of these three speakers in turn for some brief remarks. We'll come back together for some discussion. And as ever, your input and questions are really important to this series, to this dialogue. And so we encourage you to post your questions throughout the session, and we will do our best to moderate them and ensure that we have a robust dialogue. So again, thank you for being with us. And with that, I will gladly turn it over to Dr. McMurray-Heath. Michelle.
Thank you so much. It's a pleasure to be with you all here today. And I always appreciate the conversations that IVI really stimulates. So we at Bio really agree that it's critical that we find a more holistic and representative definition of value in healthcare. I love Jennifer's comment that would hardwire, poor value assessment hardwires in current inequities. And I think that's absolutely right. And it also puts it into the coding for the future as well. So our society is becoming more diverse, and COVID-19 has really made it clear that we have a huge need for greater representation in data, all types of data. And as a result, equity must be front and center in value assessment. If we're really being honest, we've always needed to take this step, but society and industry is finally catching up to that reality. So how value is determined will have long-term consequences for future investments in drugs and treatment. Any formalized process that measures the value of a healthcare intervention sends a market signal about what society will pay for, and it presumes to know what patients really want. Misaligned signals or narrow assessment methodologies really create disincentives for investment in novel treatments that could lead to critical therapies and cures and improve the quality of life for millions of patients. We can no longer underinvest in many chronic conditions that have really plagued our minority and underprivileged communities, such as asthma, diabetes, heart disease. We need to think about value in terms that go beyond the price to the impact on society. We need to ask if research, interventions, and care can have a stimulative impact on various populations. Health has the ability to open up economic opportunity, to free families, to really pursue their goals, and to free them from concerns and worries. And we have to find a way to take this type of economic liberation into account as we're doing value assessments. So how can value assessment methodologies really encourage the development of therapies that promote these outcomes? It's important that we try to find some key tenets that I know IVI is living by every day, that we take into account every time we're talking about value assessment. At Bio, this means a few things. It means prioritizing patient-centered viewpoints and endpoints. When I was at the Food and Drug Administration, I was an advocate and a developer of patient preference technologies, and I'm hoping some of my patient preference colleagues from FDA are on the call today. But this gave me really line of sight to the fact that what patients value is not always what we presume they will value. And we need to make sure we are getting from the source what is going to improve their lives and improve their opportunity. We also need to modernize methods of data gathering and analysis to really reduce discrimination and disparities. We hear a lot about real world evidence and using big data to transform the way we do clinical trials, but this is incredibly important for equity because it gives us a lens into how people live their everyday lives rather than selecting a group that can afford the extra bandwidth, time, and economic considerations of participating in our more traditional forms of clinical trials. Third, we really need to consider the value for distinct patient populations and disease states informed by patient experience, so that we're really making sure that we understand that the same disease may afflict a 28-year-old and a 98-year-old, wealthy and a poor patient, a minority and majority patient, and we need to take into account how it's impacting their lives in a differential manner. And then finally, we need to reduce the use of arbitrary thresholds of value and have a more holistic viewpoint. That's taken together, we can really get a greater variety of data and greater participation in R&D, and we can really help more people as well as help our industry be more innovative. So for example, if you take the population in trials, if the trial population doesn't look like the broader population, how does that affect our assessment of value? What kind of biases could distort market and lead to suboptimal outcomes for all with this stilted view of the patients that medical intervention will eventually serve? This is where our view of just science really comes into play. We think science is a key tenet to social justice, and just science occurs when science is being developed, and the benefits it will bring and the opportunities it creates reach deeper into communities in ways that are just, impactful, and inclusive. It's not simply a moral imperative. It can really be a value add for researchers, developers, product producers, and our society as a whole. It's a win-win. When disadvantaged communities have the opportunity to progress, we all benefit. So innovation happens at companies large and small, and larger companies may be able to take more risk, but I believe that an equity focus will ultimately allow innovators of all sizes to really find value for themselves and more populations. The science of value assessment is still in its early stages, and to date, value assessment methodologies have only been used somewhat narrowly to suggest appropriate pricing. If we're going to use these tools for loftier purposes like advancing health equity and directing science to meet unmet medical needs, it's important that we bring multiple perspectives to work. Limiting ourselves to just a few or one potential answer to these questions risks setting mistakes in stone that haven't even yet been identified. So therefore, it's no one organization that should be tasked with defining value. A diversity of organizations should be looking at how we quantify value and its impacts. It's like we pursue any other field of science. We want a multiplicity of views attacking the problem so that we can get to the best answer faster. And this work is important to me as it is to many of you. We've seen how certain diseases and potential cures have been overlooked for years because of traditional views of value. So let's really work together to change the narrative and the process so that more people can not only receive critical care and critical innovations, but researchers and innovators can really benefit by doing so. So thank you, and I'm looking forward to our conversation.
Thank you, Michelle. That was wonderful. And I loved, in particular, your use of the word just science. I think that is a beautiful and a simple and elegant way of thinking about what we're aiming for. I'd like to welcome Dr. Roy. Hi, good afternoon. And I believe we have some slides to accompany your remarks.
Yes, thank you very much.
Thank you.
First of all, thank you so much for the invitation today to talk about value from a patient perspective. And it's such an honor to be here today to represent the lung cancer community. And I'm going to follow, I think Michelle's remarks set stage for a very, set up my discussion very well. And I'm going to sort of use lung cancer Longevity Foundation as a lung cancer patient advocacy group, and I'm going to be using lung cancer as an example for some of the points that I'll make. But we need to keep in mind that I think value from a patient perspective is essentially the same. And the reason why we as a patient advocacy group, we care about value is because we see value as a very fundamental bridge between research and innovation and access to care, which then sort of weaves into this discussion of equal access and health equity. So if you can move to the next slide, please. So this is basically the outline of my talk. And the first part, I'll talk a little bit about value frameworks in the era of precision medicine and where we are sort of falling short. And then finally sort of end my discussion with some thoughts about how we can move towards creating an inclusive value framework in the patient and the caregiver perspective. So if we can move to the next slide, please. This slide is just a level setting slide, and this is just to remind us that lung cancer is a really, really great case study for precision medicine. And if you start from the left, you see lung cancer is a very homogeneous disease. And as we sort of move to the present in 2021, thanks to advances in biology, we've made a phenomenal amount of progress in understanding what are some of the different molecular drivers for lung cancer. And I think most importantly, I think finding treatments matched to these molecular drivers. So if you see on the extreme right, the box, unfortunately, the box is a little skewed, but the first 7 molecular drivers that you see starting from EGFR and all the way to BRAF, those 7 molecular drivers have FDA-targeted therapies available. And the next 2, HER2 and KRAS, we actually will be expecting approvals in these 2 molecular drivers, hopefully in 2021. So all this is to say explosion in the precision medicine field for lung cancer is just enormous, which then brings me to my next slide, which is essentially how do we balance all of this progress with access? And one of the outcomes of non-inclusive value frameworks is the persistence of patient-level disparities. And unfortunately, we cannot have a discussion of value without drug costs. And on the left side, what I've shown you is 4 new drugs that were approved over the past 1.5 years for 2 of the mutations, MET and RET, and the cost per drug for each of these months, and the PFS, which is essentially the quantity of life that, the quantity of cancer, a quantity of life that a particular drug offers where the cancer is not spreading or growing. So PFS is progression-free survival. And as you can see that there's a balance between PFS and cost, but the reverse to this conversation is access, which is our minority communities, our underserved communities really benefiting from all of this progress. And I've again given you 2 examples there. There is a lot of evidence that patients on Medicaid or on public insurance do not benefit from these advances in research and treatment. And the same is true for also racial and ethnic minority groups. There is also a lot of evidence that African-American patients do not benefit from targeted therapies. And moving on to the next slide, please. And this is, again, another reason why we should not have non-inclusive value frameworks. And this is actually a great paper, and I recommend that all of you read it, which talks about safety net hospitals. And on the table in the left, a high safety net hospital, as we can imagine, has a higher proportion of underserved community members in terms of racial and ethnic minority groups and also income. If you just advance a little bit more. Thank you. Now, this is essentially using traditional quality metrics to evaluate outcomes from these hospitals. And as you can see, the difference between high safety net hospitals and low safety net hospitals is quite high. So if we use traditional value metrics to drive reimbursement, which is what often value frameworks are used for, then what we end up doing is we end up disincentivizing some of these safety net hospitals to really care for the underserved, because at the end of the day, that'll essentially drive down their profit margins. Next slide, please. So which then brings us to this very, very fundamental question. How do we create a value framework that captures population level benefits? Because that's where value frameworks start, at the population level, is inclusive and incorporates patient preferences and experience, and is aligned with the tenets of precision medicine. And yes, this is a very challenging task, no doubt about that. But I think this is the time to have these discussions. As Michelle pointed out, the science of value frameworks is relatively nascent. So this is the time we should be having these types of conversations to make sure that we make these frameworks really, really inclusive. Next slide, please. So the first thing that I encourage all of us to think is developing a framework of inclusiveness. And I think when we think of health disparities and access, I think we tend to sort of think of it in a unidimensional fashion. But at the end of the day, we need to realize that patients wear multiple identities. Some of these identities are clinical, some of these identities are societal, some of these identities are cultural. And at the end of the day, I encourage all of us to think of the lens of intersectionality when we're thinking of inclusiveness, because no patient wears one single identity. Next slide, please. The next piece is we need to be conducting research. We need to be coming up with better methodologies to understand patient heterogeneity. I think all of us on this discussion can agree that no patient is the same, and patients have different biologies and different preferences. And I'm just using two examples from lung cancer on the slide. On the left side, you see patient heterogeneity in terms of biology. And again, two of the biomarkers that I talked about in my introduction, KRAS and EGFR, as we see, the proportion or the prevalence of these biomarkers is quite different in the East Asian community, in the European community, and the Latin American community. And it's not just the prevalence of these biomarkers, but there's also a fundamental difference in biology. Some of these mutations are actually different in different communities. And on the right side, I use an example from our patient preference study, Project Transform, which we conducted at Longevity Foundation, where we looked at patient preferences and we did a trade-off study to understand what patients value in terms of quality and quantity of life. And here for quality of life, you've used long-term side effects as a measure, and for quantity of life, you've used PFS. And as you can see, patients who identify as belonging to a racial and ethnic minority group, their preferences are quite different from patients who identify as white. So hopefully I've convinced you that patient heterogeneity is extremely important to understand and codify. The next slide, please. And finally, I think we need to be creating a patient-centric model. All our value assessment frameworks thus far have taken this very top-down approach where patients have not been included. But I suggest we sort of flip this model and use a bottom-up approach where patients are truly front and center of this discussion. And what do we really need for true patient centricity? I think a couple of things. First of all, we really need to develop better capacities for reach, trust building, and patient engagement. And I encourage us to think of sustainability in this engagement process, because again, I don't see this as a one and done engagement. The second piece is better ability to capture biological heterogeneity. I think we need to make progress in that area as well. The third piece is incredibly important: better methodologies to capture and incorporate patient experience, both quantitative methodologies and qualitative methodologies. And finally, I think we need to have much better ways of collecting data, sharing data, including consenting for the use of data. And next slide, please. And this is my last slide. I know today's discussion is focused on equity, but I would really encourage us to ground our discussion, our framework in the concept of justice, because that is ultimately what's going to lead to access and distribution of healthcare resources. And again, thank you very much, and looking forward to questions and discussion.
Paul, thank you so much for framing that and giving us a very concrete example to guide our discussion today. So thank you for that. Tasha?
Thank you for the opportunity to greet you today. As Jennifer introduced, I'm Latasha Lee, and I'm with the National Minority Quality Forum. For those of you not familiar with NMQF, we are a nonprofit based in Washington, D.C. and founded in 1998 to address the critical need to strengthen our national and local efforts to use evidence-based, data-driven initiatives to guide programs and eliminate disproportionate burden and premature death, particularly in racial and ethnic minorities and other special populations. So I'm really pleased to join today's conversation. As Jennifer introduced and Drs. McMurray, Heath, and Roy so eloquently highlighted in their remarks, there are many current assessments that are insufficient, both in their lack of representative diversity and their failure to capture real-world factors that really matter most to communities of color and those living with chronic health conditions. And these inequities really result in disparities in care, access, and outcomes. So as we talk today about value assessment, as the healthcare costs in the United States continues to have growing interest in reducing costs and moving towards value-based care in terms of patients and payers paying for the quote unquote value that patients receive, it has become increasingly a renewed interest to look at tools for controlling healthcare spending. And while there is merit for paying for services that would eliminate wasteful spending, I think it's really important to set this in the context of equity as well as to whom this value is being provided. Echoing what Upal mentioned, really thinking about the patient as the end user because they are the ultimate beneficiary, and we really do at NMQF value and advocate that the measure of value in a healthcare setting should really focus on the value to the patient. But right now, the trend really has been focusing on the value to the payer, whether that is the government or other payers. Apologies, I had a little alert saying I have a reduced internet, so I hope I'm coming in clearly. But a lot of that value to the payer is really focused a lot on reducing care, reducing costs of care versus the outcomes and perspectives of the patient community. So I'm really pleased today that we're really talking about equity. But when we start talking about value assessments, there are several common tools and resources that are used that determine the incremental cost effectiveness of certain interventions. And one of those that many are familiar with is the quality or quality adjusted life years. And no stranger to this, but NRQF is not a favor of the quality. In fact, we feel that there are serious ethical or equity concerns with how the qualities have ultimately been developed and used. In short, this measure really does look at a disproportionate look, I guess, at individuals and really values perfect health over those that have less than perfect health. And that is really fraught with issues. So many of you may know the quality, and if not, I will put a reference to a paper that Jennifer indicated in her early remarks. But in traditional methods such as the quality, but there are others, there is inherent bias. When you start talking about many quality assessment tools, they utilize and rely on data from randomized clinical trials. And the issue with clinical trials and even the health utility preference weighting surveys that are often utilized is these often rely on inputs from primarily Caucasian populations. And when you're talking about clinical trials, primarily white male populations, because they really tend to be skewed that way. And we know that in clinical trials, it's fewer than 10% of Americans actually enroll in clinical trials, and you really have a lack of enrollment from people of color and diverse communities. There are also systemic inequities that are present within our current system that disproportionately impact communities of color. Also, population averages are often utilized in value assessments, and these really rarely report specific data around minorities. There was a recent review, I think it was in 2019, that looked at cost effectiveness analysis, I'm sorry, 2016, that found that 19% reported patient subgroup results and only 4.4% reported on and race and ethnicity specifically. So when you're talking about inequities, that's an inequity that's systemic right there. Additionally, I highlighted this when I started talking about the quality, but many of these measures really do assign lower value to patients with disabilities and chronic conditions. And why this matters is African Americans tend to have higher rates of early onset of chronic conditions as well as disabilities. 25% of them, African Americans in particular, have diagnosed disabilities, and Hispanic Americans have significantly higher rates of obesity and diabetes. I think lastly, many of these designs really do not incorporate outcomes that matter most to the patient. And as Paul mentioned, we really have to look at what the patient values, and especially look at the social determinants of health when you're talking about inequities. This failure to incorporate these outcomes, which matter most to patient, really include things such as lost productivity, the caregiver burden, outcomes that typically are not really looked at in value assessment. but it becomes especially problematic when conducting evaluations and treatments for communities of color, because research has shown that generally these patients have less savings, dollars. They are less likely to be in salaried positions. They're less likely to have sick leave or paid sick leave, and smaller social support networks, and more likely to be uninsured. Therefore, there can be really indirect effects and outcomes that have more pronounced views and ways when you look at value assessments in these communities. So really what I want to leave you with as we move towards the title of this webinar, A Meaningful Action Towards Health Equity and Value Assessment, we must put patients at the center. As Paul mentioned, we have to ensure that they have a seat at the table and it's meaningful and continued, not a one and done. And we should no longer also look at a one size fits all or homogeneous approach to value assessments, because we know that our populations are heterogeneous. I want to leave you with the paper that I mentioned, and Jennifer, I think, is going to put it in the chat. But it was a white paper released last fall by NMQF and PIPSI, titled "Traditional Value Assessment Methods Fail Communities of Color and Exacerbate Health Inequities." And I really would love for you to look at that as reference as you continue this discussion. Thank you. Oh, thank you, Erica. She also placed in the chat. We will have our annual summit next week. It starts on Monday, and the link for registration is there. It's virtual, and we welcome you all to that conversation. Last year's topic really did focus on value assessments and that paper that I mentioned.
Thanks, Tasha, and thank you for sharing both of those resources. And I'm sure, like many organizations that are digging into some of these issues, that your summit is going to be wildly successful, and hopefully you come up with some additional solutions. I'd like to invite all of our panelists to come on camera with me, so we can at least look each other's pictures in the eye and have a conversation. I also want to remind our audience that you can post your questions to the Q&A, and we'll be monitoring that. I could spend all day listening to each of your presentations. They were so, they fit together so nicely, like puzzle pieces. And at the same time, you each brought some different themes forward. I think my biggest takeaway is always, we seem to have a good handle on that there's a problem, first of all, just writ large, and that there are some clear pathways to improvement. So my question to you, and maybe I'll work backwards, starting with Tasha, is what's holding us back? Where do you see the biggest areas of inertia, either within your communities or just writ large? I'd love to explore that issue of what's holding us back first, because I think that is the first thing we have to do, is to unpack what's stopping us so that we can move it out of the way so we can get forward. So Tasha, what do you think?
So I do want to applaud groups like IVI and others who are really tackling this, but I think part of the problem always is that we often work in silos. And working in silos often doesn't disseminate the information to those who really could be utilizing the tools, solutions that are being moved forward. So that's one solution. I think the other is really what Paul mentioned, is really focusing on patient centricity. A lot of people like to talk about they do patient engagement or they do patient centricity, but really taking those best practices and employing them to things like value assessment is key, and ensuring that that is done equitably. Just because you have one patient representative does not mean that that represents the views of all patients. And I think that you have to take a broader approach.
Paul, what are your thoughts there?
I think Tasha did a fantastic job, and I don't have much to add. The only thing I would sort of bring up is in terms of from the methodological perspective, I think most of the data that's been gathered and that's used to develop value frameworks, they come from a specific group of hospitals, trials, and they really do not capture the spectrum of patients as we've discussed. And I think we really, at this point of time, I think it's a very good idea to sort of realize the limitations of the framework And let's be honest, I think coming up with a perfectly equitable framework is going to take time. It's going to take an investment of money, of resources. And I think we need to be aware that it's going to take a long time. But before that, the frameworks we develop, we need to be aware of the limitations of those frameworks.
Great. Michelle?
You know, we had our Hill visit this week with our board members. And so in 2 days, we had 50 meetings with members of Congress and members of the White House. And it just hit me that we are dealing with a completely antiquated sense of what we need to do for health equity and health justice. We think it's all about opening the doors to the hospital, getting people's doctor's appointments, and that in and of itself will solve their issues. And it really belittles the adversities that a lot of minority communities face on a day-to-day basis, and many non-minority communities that are rural, impoverished, dealing with other chronic health conditions that are standing in the way of their day-to-day enjoyment of their lives. And so we have to get to a conversation where we say, if the research is not equitable, the resulting health cannot be equitable. And research is as important part of this conversation as absolutely anything else. And we have been reluctant to do that to date. And our members of Congress are not even thinking about it for the most part. Their equity is, almost all of them mentioned equity in the course of their meeting, but it was all about bring down the cost, and that's going to solve all the problems, instead of having a conversation about whether or not we have equitable remedies for them available.
I think all of your remarks are so perfect. You know, you hit on all the themes. I agree, you know, Tasha, that silos, that's a big thing that for me personally and in my career, I've worked really hard to try to break down silos and to bring people together. And I think that's a major contribution that IVI wants to undertake. Not that we have all the solutions, but what we want to do is look across sectors and actors in the space and say, who's doing, like, what's best in class, who's leaning in and really accelerating, and how do we build on each other's work as opposed to try to have a horse race for who can get the best journal article published or whatever. I mean, no harm, no foul, but it's my view, exactly as you said, that we're not going to win this battle, which is significant, if we all keep playing in our own sandbox. And Upal, you talked about time and resources. I think that was one theme I wanted to call out, which is this is a big issue. This is not for the faint of heart. And I think one of the challenges I see is that the policy, to your point, Michelle, the policy engine is looking for what it normally does, which is what's the simple solution? What's the low hanging fruit? What's the thing that will satisfy people enough to have them stop calling my office? But the answer in this case is not simple. It is going to take a lot of work. It is going to take a lot of rethinking and relearning what our assumptions are about what is equity, because I think oftentimes when you see that phrase, people automatically go to it's about race and ethnicity and disparities there. But as you pointed out, it's gender, it's socioeconomic status, it's geography, it's, you know, it's other cultural issues within your community. And we don't do a good job of understanding that or even asking good questions about that. And then lastly, you know, I think the business model is wrong, to your point, Michelle. Like we're starting from the wrong lens, which is it's just about price or cost. I think at IVI, we really believe that that value assessment can serve other purposes for decision making, and that's what we want to explore. I think, you know, so all these points really tie nicely together. I think one question we have in the chat.
Jen, we have a.
Yeah, no, I was just getting to one question that we have in the chat that you each have hit on is this notion of representativeness, both patients at the table, but also representativeness in research. And this is a big area that we need to lean into. What are your thoughts about, are there kind of good practices you can point to that you see in your communities that we need to pay more attention to? Are there certain practices that you would recommend our audience really dig into to improve that process? What are your thoughts there? Maybe let's start with Upal this time.
I think a couple of institutions, such as the UT Southwestern Medical Center, they've done a fantastic job engaging minority communities in clinical trials. And I think one of the things I do want to point out again is when we are thinking of representation, I think we need to also just not use one lens for representation and think of multiple lenses. And I think the other piece here is trust building. And I think if we do not use community-based organizations to build that trust, to really bring patients to the research discussion and use much more of a participatory action, sort of a participatory model of inclusion. And this is something we hear from patients all the time, that when we come to the table, it's a little bit of an afterthought. Why were we not involved in these discussions when a study was being designed, when a protocol was being designed? So one of the things that the UT Southwestern Medical Center has done really well is sort of bring patients up front, right from the design conceptualization of a study protocol all the way to study result dissemination. And I think this practice, this participatory practice goes a long way to develop trust and community building. I think that's the first step to leading to representation in research studies.
Tasha, you mentioned, one patient doesn't reflect a whole community. Do you want to talk a little bit more about what you meant by that, and also how you're thinking about operationalizing that in terms of advice for researchers?
Sure. I know we're all pretty familiar with what we call the professional patient. It's the one patient that everyone goes to for a particular disease state. And I think we have to get beyond that. We have to really look at intentionality and look at the diverse community in which patients represent. Oftentimes, that squeaky wheel is the one that gets the most attention. And while that's great, oftentimes those perceptions are not those that represent the entire community. I think when you start talking about specific disease states, it's really also important to look at access issues, because if a person that you're having as a stakeholder, in your discussions represents a community that has lots of resources, has clinical trials available, has knowledgeable providers, they don't necessarily represent the full patient voice, and that's important. I think to answer the question that you posed as well earlier was that we have to be intentional. You can't just, try to engage someone late in the game. Be intentional and be very meaningful in your conversation. Oftentimes, I've seen people try to tick a box to say, oh, I had this person on, I had this representative. But if you're not level setting, if you're not having conversations where they're actually able to give meaningful dialogue and contributions to discussion, it's not really doing its job. And then I hate to go backwards to your previous question, but you left off with something I'd be really remiss not to mention, because our president and CEO of NMQF has really taken on the notion of really talking about patient risk versus financial risk.
Yes.
And we really do need to shift the paradigm here in the US, because we focus so much on financial that we are neglecting what is at the center and forefront of the issue is the patients. And if we're not addressing those issues facing patients and what matter most to them, we really are doing ourselves a disservice, and we are continuing to do the same thing. And they say insanity is continuing to do the same thing and expecting different results.
Yeah, and to your point, when we talk about financial risk, typically I see out-of-pocket costs associated with patients, and that being the only factor of cost or financial impact. We have to get out of that box. There are so many more impacts to family and job and things like that we're not accounting for at all. So it's not just about your copay and your deductible, and we have to find ways of measuring those things and putting them as part of the equation. Michelle, sorry, jumped in before you got your word.
No problem at all. I was actually thinking of weaving together some of the great points that Upal and Latasha made. We need to think about it from the endpoint design stage of research. What was so clear from Upal's data is that different communities don't judge the endpoints in the same way. They don't value the outcomes in the same way. And so we need to have patients at the table in a representative manner, weighing in on who should be in a trial, what should a trial even measure, and how do we know if a new medical intervention is a success or not. Until they're involved in that initial stage, the value assessment piece is going to be in a difficult bind, because at best, you're going to be offsetting the results from the initial clinical trial, but it really should be working hand in hand. And I think it's so key, the point that Latasha raised about the professional patient, even the professional minority patient. We need to make sure that we are delving into communities in a systematic population level way, and not just an anecdotal individual way that doesn't get at the heart of what's really important to whole communities.
That's a great point, Michelle. And Upal, you mentioned intersection with community groups, and Tasha, you and Michelle both talked about patients at the front, and and Upal, you did as well, in terms of study design. There's a lot of questions about the how. So in addition to doing better outreach using existing community groups that may have better relationships with and cultural connection with different communities, and also this notion of patients first and partnership, other strategies that you have for improving representativeness?
I can start it off if it's
Sure.
okay. So one thing we utilized a lot when I worked in sickle cell disease is the use of community advisory boards. And I think CABs are a wonderful model that really do get at the forefront of some of those really important questions. And when you're talking about community, it's not only the patients, it's also their caregivers. I think that's a big missing piece of the conversation often. Whether it's talking about clinical trials, whether it's talking about what impacts, outcomes, et cetera, matter most. Sometimes it's the decision of the family and not just that of the patient. So I think that's important. I think it's also key to go to where the patients are, meaning establish relationships in community. It doesn't always necessarily mean a community based organization or CBO, because in some communities they're not there, but they often do have. Groups within hospitals. So you have, support groups, et cetera, that are there for the patients. Ensure that there are, you've established relationships with social workers who often care for the patients, know the needs, and can outline some of the challenges that a patient experiences. I think there are lots of ways, but I saw that there was a question about trust. Trust has to be built. It's not easy. Whoever tells you it's easy is doing it wrong, and is not doing it effectively. It does take time. You have to build it and come from a place of being genuine, and not just trying to, achieve a certain vision. And I think shared goals and decisions are important in that process, so that they feel that they are part of the discussion and not just being used or utilized to help you meet your goal.
Yeah, and one thing I want to weigh in on that concept of trust is, I think oftentimes we forget the feedback loop. We forget to bring back to the communities that we're partnering with in research and tell them what we learned and what we are still not, that we don't have our hands around. I think patient communities writ large are very accepting of when the answer is not clear. But when we pretend that we've got all the answers, or we take from them and then just go off and do our publications and what have you, we don't build that trust that you're talking about.
I think also, to the point of pretending, sometimes we always pretend that we are the experts, but we don't have that lived experience like the patient. And so go in honestly and say, I know this disease from this perspective. You are the true expert. It really does show the patient community that you value and respect their position, their role, their lived experience.
Those are all great points.
Just quickly add to what Latasha
Sure.
brought up, Jen, and the piece of intentionality, and then your point about reporting back to the patient community. I think the other two pieces that we need to be very clear about is accountability and transparency, which goes back to giving back to the patient community. And another model which I feel has not been exploited that well in the research setting is using community health workers. And going back to Latasha's point about not every community has a CBO to serve them. A community health worker model has worked really well from a public health intervention perspective. So there's no reason why a community health worker model would not work in terms of recruiting for clinical research. And the other piece I think we all need to keep in mind is engagement tends to be hyper local. So an engagement practice that works in institution A, it may not work in institution B. So I don't think we should be working on this assumption that we can just replicate and scale up an engagement practice from institution A to institution B. And we need to be aware that we might need to start from scratch in a separate place.
Boy, talk about making the hill steeper, Upal. That's okay. That's what this session is framing. So you all have the luxury of not having to have all the answers. You could just lay out there what your view and set the bar. We have a couple of questions in the chat, which I want to point out are more methods focused. And that is going to be the emphasis for the second in this series, to really dig into some of the novel thinking about methodological approaches. But Tasha, since you raised the challenges of using QALY, and this would be an open question to all of you, but what are some of the strategies that you're looking into or that you think the research community needs to dig into more from a method standpoint to better address some of the issues you've raised? Any thoughts there?
So I'm going to just put a disclaimer. I'm not an expert on quality or methods in this space. I'm a PhD neuroscientist. So I would love to see something that has equity in its name developed that really looks at how to have an equitable framework for value assessment. Whether that means taking into account all of the different racial and ethnic, but also equity in terms of the disability group. I think a lot of the flaws that have been highlighted in terms of abuses and quality really do focus around the disability and chronic condition community. And I think that we really do need to create a measure that has everyone at a seat at the table to really address the flaws and create a tool that can be utilized by all to address the challenges we face currently. So that's not really a real answer to your question. Sorry.
No, but that's a gauntlet you just threw down. So Upal, any thoughts, or Michelle, any discussions that are going on within your communities about alternatives, areas of exploration?
Well, I'm not a methodologist, but I'll just throw in there that we also need to get comfortable with the fact that we may have different communities may come up with a different final answer. Like the same intervention might be of different value to one community versus another. And I don't know how we wrap our heads around that, but I think just trying to amalgamate everything into the mean may not get us to where we want to be.
Upal, any additional thoughts?
I think Michelle and Latasha covered it
Yeah.
well.
So I will say, at IVI, we've been exploring and will continue to do so, looking at novel methods like multi-criteria decision analysis, which it endeavors to get at what you just said, Michelle, which is how do different communities weight things differently, if you will. But I think one of the prior comments that all of you made, which is what are the priorities? How do we know what the most important information is and to feed into those kinds of tools? They're not definitive answers. They're tools that help us take data and perspective and shape it into a picture that we can use to compare against what the real world situation is that we're having. I mean, that's the purpose of modeling. And again, I'm not a methodologist anyway, so you're all in good company. But in my mind, a model is a way of understanding a picture and to guide your thinking. It's not an answer. It's not a black box. It's not a tool kit, that says here's the answer every time. And so, I think that's how I think about methods, is what are the best ways of representing that multiple perspectives. But there are others. And again, like I said, the second in this series, we are going to have methodological experts at the table. And so I'll use that as a teaser for our next session. I'm looking at some of the other thoughts or other questions, but while
you look at that, Jen, I just wanted to mention, I have always thought that we could find minority clinicians and minority patients in almost any setting if you look hard enough and work towards that goal. But I also think that we also have to pay attention to minority serving institutions. I had the great fortune to get my COVID vaccine at Howard University's hospital, and I didn't attend an HBCU for undergraduate or graduate school, but I've got to tell you, the look and feel of walking into an institution where all of the clinical leaders are people of color was such a different look and feel. You know, what they had on the bulletin boards, the patient information pamphlets, everything was a different orientation than the hospitals I was used to. And so I think we have to try to gain from those experiences as well. And there's only a handful of them, so it doesn't help us answer the entire question. But I think they can inform inputs, endpoint study designs, and how we judge value in some of these communities as well.
That's a great point. I think I wanted to take a few minutes to talk about priorities. All of you use that word at least once in your remarks. And, you know, last February, IBI hosted a Method Summit in which we talked about patient perspectives and how they need to be represented better in value assessment. And one of the uniform responses was, yeah, but we can't include everything. So what's the most important aspect? So I wonder if you have some thoughts and whether you've talked within your organizations about where are their priorities that we can all agree we need to dig into. PCORI just announced their new principles for exploring patient impacts and what's important to patients. And that's an opportunity. But I think one of the things that we all suffer from in our various silos is, what do we do first? Where do we start? Are there common things that we should be measuring that we're not measuring across disease states? You don't have to have an answer, but I'm just curious whether you have some thoughts on priorities and where do we begin?
We've been thinking about this in depth from a policy perspective. You know, if you're designing policies to try to improve clinical trial diversity, where do you start? You can't boil the ocean. And I really think we need to ask ourselves, what are the 10 disease areas with the biggest differentials in mortality and morbidity between minority and majority communities? That is where we can hone our skills, really find what's going to get to the answer, and probably measure health outcome impact faster, sooner rather than later. So that's where I would start.
Okay, so policy or priorities from a standpoint of looking at chronic disease areas that are biggest impact and starting there.
Exactly.
Upal or Tasha, thoughts?
No, but I agree with Michelle. One of the things, for those of you not aware of NMQF's work in big data, is we have what we call the National Health Index. And in various diseases, we have over 5 billion patient records where we analyze healthcare utilization, demographic data, et cetera, on patients. And one of the things that I tasked myself with when I came into this role last summer was really looking and creating a priority matrix of where do we see a disproportionate impact of a particular disease in communities of color, and really emphasizing those as priorities for our organization to move forward. But I think that that could be something that we could do broader than just NMQF's work. So if anyone's interested, please reach out to me and I can share with you a bit about some of our indices and where we see, you know, a disproportionate impact of a disease burden and where we think that, you know, attention could be drawn. And we have what in our index, and I'm not really describing this well, I should have had a slide for this. We analyze data by zip code. And so you can see the disproportionate impact of disease across the US by 5 or 3 digit zip code. So you really know where to put your policy efforts or programmatic efforts into. And I think that's one. But Jennifer, if I could pivot, there's a question in the Q&A that I wanted to address.
Sure. I bet we picked the same one. Go for it. Which one?
How to address the reality that in some communities, participation in research and clinical trials is understandably seen as potential harmful or risky. Was that the one you were thinking?
It
was. So I've been working in this clinical trial space for a bit, focused around patient understanding, perceptions, and awareness of clinical trials. I think it's really important to change our perceptions of what that is. Yes, minority participation in clinical trials is not where we want it to be, especially considering that the 2010 and future 2020 census indicates that we're going to be a majority minority country in 2050. And in doing so, we have a really disproportionate share of our minority communities participating in clinical trials. But the reason often is not only solely with the patients. And I hate that we continue to have that narrative and conversation that it's the patient's fault. I'll put a link in the chat to a Research America study from 2017, but they did an oversampling of minority communities and found that trust is no longer a barrier in clinical trial participation, or no longer a significant barrier. The biggest issue that people have stated was that they're never asked. And part of the reason they're never asked is because we continue the narrative that they're not interested, that they don't trust, that there's all these institutional abuses. In my work with the sickle cell community, our paper is forthcoming, so I hope all of you will go put a PubMed search on for that. But when I was at the American Society of Hematology, we reached out to the sickle cell disease community. And the majority of our patient population indicated they would be interested in a clinical trial. But we asked, what were your barriers? I said, well, my clinician never mentions it to me. No one's talked to me. When I've talked about participating in clinical trial, it was dismissed. But we have to acknowledge implicit bias in our system and the systemic racism that is existent in the US medical system that prohibits and discourages involvement in clinical trials. We can no longer talk about Tuskegee, let's be honest. Yes, we can talk about it historically, but that's often not the reason why the majority of millennials and younger populations aren't participating. They're being, unfortunately, lumped in with past historical, enrollment, issues. And we just have to get past that. And I think one of the things I really like to talk about is truth and reconciliation. Yes, it happened, but this is how we reconcile. This is how we're moving forward. And these are the things that have happened since, Tuskegee. And when we have those honest and frank conversations with patient communities and they understand the process, they're more apt to participate. NMQF, and this is my last spiel, NMQF is doing a COVID study right now, a long-term longitudinal study of COVID-19's impact on communities of color. And our goal was to enroll 5,000 individuals. We're at 4,000, and they're majority minority, and the majority of them are Latinx. And people are like, oh my goodness, how do you have so many? And it's because of trust. We're utilizing, similar to what you Paul mentioned, those trusted individuals in community. And while they're not community health workers, we're working with federally qualified health centers who really do have a trusted relationship in community. And I think that's important when you're having discussions around that. It's not always the major academic medical centers where clinical trials are taking place. You have to look at where those patient populations are. And through some of our partners who are members of BIO, Michelle, we are creating indices around clinical trials of where these patients are. And it's important to look at that index when you're designing your clinical trial to make sure you're putting these trials and sites that reach the population you're trying to address. I know that was a long spiel.
No, but I think you're bringing out exactly what we're hoping, which is the creativity it takes. It's not a one and done thing, and we have to pull the layers back. And one thing we found in our work in the area of depression is that we also have to think outside of our tech world, right? Many individuals whose input we are seeking do not have access to be able to do electronic surveys. They're not reachable via email. They are found by partnering with clinics or FQHCs or direct, community health centers who are providing these services, and they need to have that warm touch, that hand-to-hand interaction in order to feel comfortable and safe sharing their experience with, but that's vital work if we're really going to understand the experience of a person with major depression who's on Medicaid and, may have an unstable housing situation. We are never going to understand that person's experience if we don't find a way to get to them. And so that leads me to,
Can I just jump one other thing on that point? So sorry, Jen.
Sure,
I think it's also really important for us to acknowledge that clinical trials can be risky. and can do harm. And that's part of the paradigm, but we have to put it in context. You can't establish trust and credibility unless you do recognize the reality of the situation and then help people interpret that reality in their context of their lives. I think that's very important as well.
Yeah, and to your point, that building of trust, having that trust communication acknowledges that there are risks and benefits. Nobody's expecting an entirely unrisky situation in participating in a clinical trial, but when we try to gloss over it or skip it altogether, that's when you breach the trust, right?
And if there's no risk in the trial, we don't need the trial.
Right.
So we have to acknowledge that.
Yeah, so that's a great segue. We have many questions, which I'm thrilled to see. A lot of them have to do with methodological questions. And so I'm going to those of you who have asked them, thank you very much. I'm going to reserve them and pull them as our driving questions for our second webinar, because we really are going to dig into methods there. About internal validity and all those fun things that I know Rick Chapman will be much better equipped to deal with. But I want to, as we conclude our time together, I want to go back to a major point that Upal made early in his remarks, which was this is going to be a resource-intensive, time-intensive investment to get on top of these challenges. And I wanted each of you to reflect on that. How are we going to create the conversation that's willing to invest the time in this enrichment of patient centricity and perspective? And how are we going to find the resources? I would love your reflections on both those questions as we close out. Let me start with, perhaps let me start with Michelle, if I can put you on the spot for that.
I am so sorry. My assistant was trying to get a hold of me urgently, so I missed the question. Would you mind repeating it?
That's okay. So I was saying that Upal raised the issue that this is a time-intensive and resource-intensive endeavor that we're talking about. How do we improve representation and patient perspective inside value assessment? How can we begin to identify resources to do this work? And how are we going to create the patience, I guess is the right word, in the policy discussion to invest in this effort? Because I really do believe we all agree, this is worth doing and we have to do it if we're going to have good decision making. So how do we get people to not only pay attention, but to lean in and resource the work that has to be done?
And I think it really is a challenge. And we've been struggling with this from a policy proposal point of view for the last few months. If you are a sponsor, if you're a company who's trying to produce a new drug and you're trying to get it out there to market, you are probably in a race with several other companies at the same time. And so taking on something that is going to be more expensive and more lengthy is a huge business risk. And the decision may not even be yours. It may be your investors. It may be your partnership with a larger pharmaceutical company. Many people will weigh into that decision. So we have to find a way to level that playing field, which may include requirements from regulators. It may include mandates from government. We have to find a way to level that playing field. But then we also need to make sure that's balanced so that none of those levers discourage innovators from pursuing the questions that are most important to minority communities. We don't want to dissuade them from studying areas where they, to meet the prevalence of minorities that have that disease, they view it as more difficult to do the research. So sorry, that's a long answer, but I think striking that balance is challenging.
Upal or Tasha, any thoughts?
I think I'll basically echo what Michelle's said, but I think the other piece to sustain, and I use the word sustain because this is not a one and done engagement, is to remind people that the long-term return on investment is going to be really, really high. And there is data right now that says that for clinical trials, patient engagement in the protocol design and execution leads to better trial recruitment and retention. So the ROI for single clinical trials, that data is already there. And I think we just need to kind of bring out that value proposition to our stakeholders that yes, this is going to be a long-term project, but the long-term ROI is also going to be equally enormous and amplified.
Do you think that, I'm not speaking for or encouraging PCORI, but, they recently put out their principles in which they talked about the importance of really identifying factors that are important to patients and really understanding both the cost impacts and the different perspectives of patient communities. So I think they celebrate in principle a lot of the things we've talked about. Do you feel that that's an opening, that's a possibility to encourage more investment in research, that maybe a year from now we're talking about different things, like how we leverage the findings of all this research?
As a member of the PCORI board, I'll probably defer for the most part, but I will say that PCORI is challenged trying to find the balance between the new legislative mandate to be able to take cost into account and their historical mandate not to weigh into value assessment.
Value. Mm-hmm.
So and I don't think that question's been fully resolved.
But I think possibly one of the biggest steps forward is that they can begin to invest in more of the inputs. And that's vital because, as we all said, the inputs aren't necessarily either representative, nor are they capturing perspectives that are most important to the patient community. And I know that's been central to PCORI's mission in terms of their comparative effectiveness research. But it's like we have to go a little bit further to begin to normalize the notion that investing in that kind of research is essential. Well, I want to say thank you very much to all of you. We certainly didn't come to one solution, but I think that this was exactly the kind of conversation that we wanted to start. We have some wonderful questions and interaction from our audience, and thank you so much for putting those questions in. And I do want to assure you that your questions we will take and weave into our future sessions to make sure that we bring forward some thinking and perspective and solutions that are oriented to both methods and policy solutions. Before we close today, I want to say thank you to our three panelists today. It was a pleasure to speak with you. I also want to call out that we have, in addition to this series, we will be hosting a webinar on May 3rd to showcase our model scope on major depressive disorder, which we've been working on for almost a year with a very comprehensive advisory group that includes patient communities, employers, payers, HEOR experts. And we've invited several of the members of that advisory group to join our CSO, Rick Chapman, and our research manager, Richard C. We will have Jessica Kennedy from Mental Health America and Ned Kusti, who's worked for a long time in the employer community and cares very passionately about this issue. And so we hope through that webinar to showcase not only the scope, which is out for public comment right now, but also to talk a little bit more about how IVI is working in this realm to make change happen in a real and tangible way. So with that, I will say thank you to all of you for joining us. We hope to announce our second session and speakers that will focus on the methods and value assessment that support health equity and we're targeting late June for that. So watch for that to come. And we, of course, welcome your feedback. You can reach any of us on the IVI team to share your thoughts about today's session, your ideas. And of course, as always, to Tasha's point, we have to break down silos. So your participation and collaboration in this work is essential. And we are always, our door is open to talking with you about how to improve our conversation about value in the US. So with that, I will say thank you very much for your attention, and we look forward to seeing you again soon.